Steven Roy Goodman, host of Higher Education Today, a production of the University of the District of Columbia. Welcome back to the education program that connects you to contemporary issues, people, and institutions involved in the world of higher education. Today we'll be talking about emergency medical services. Holly Frost is Assistant Dean of Emergency Medical Services at Northern Virginia Community College. Holly is author of the Instructor's Resource Manual, Anatomy and Physiology for Emergency Care. Checharna Wilson, who goes by Cece, is EMS Captain and Battalion EMS Supervisor for the District of Columbia Fire and Emergency Medical Services Department. Cece is also an Advanced Life Support Instructor. Welcome to both of you.
Thank you. Thank you for having us.
Sure. Well, pleasure. Thanks again. Holly, maybe if we can start with you. Why would a student come to Northern Virginia Community College to study EMS?
Well, EMS education is actually pretty popular probably anywhere. There are a lot of reasons people want to do this. A lot of people join it because they've had a bad accident, they've had a good treatment by their EMS providers that responded to them, and they want to try it from the other side. Maybe they've seen TV shows and it seems like a glamorous thing to try. In our region, there's actually volunteer EMS that's still alive and well, which is fairly unusual. Usually volunteer EMS is in more rural parts of the country, but in the Northern Virginia area anyway, there's active volunteer EMS, and so it's an unusual hobby, but it's a very rewarding one, and so they may join it for that reason.
And Cece, why did you decide to get involved in EMS work?
Well, originally I moved to an area that actually had a strong volunteer department, and it was a profession growing up here in the city that I'd never even considered. So when I moved there to Virginia, I thought, okay, this is something that sounds like it's fun and I could try it. And so once I got a taste of it, and started meeting all these new and interesting people and doing these things that I'd never envisioned myself doing, 16 years later, I'm still in it and I still love it.
And did you decide you were going to take some courses to decide to advance in the field?
I did. Once you get in, you have at least I did. I had no idea. I was new to the whole system. I had no idea what I wanted to do. I knew there was this thing called EMT, Emergency Medical Technician, and I also knew there was this thing called firefighting, neither of which I ever thought that I was capable of doing. And once you sort of get into it, hopefully you're at a place that promotes education like my original starting place did. And it was a thing of just take any course that's offered, and the next thing you know, you have many certificates and many things that you can do, and it's a great profession to be in.
Well, in terms of the many certificates, Holly, what are some of the certificates or the subjects that a student would study if they were to not know anything about this and then just decide to jump in?
Well, EMS is a multi-leveled or multi-tiered profession, as many are. So the entry-level position is EMT, or Emergency Medical Technician. We used to be called EMT Basics, but the word basic has gone away. So EMT is the first level. There is actually one lower called Emergency Medical Responder. It used to be called First Responder, but that isn't really pursued very much. It's that would be sort of a glorified first aider, so to speak. So EMT is first, and then intermediate is, as the name implies, sort of an intermediary level. And that's not a national level any longer, but that's very strong in this area, and that's being continued in this area, even though it's not a national level any longer. And then there is the paramedic at the top level. And there's a new level in between called an advanced EMT, and that's a brand new national level, and that's in between EMT and intermediate. It gets very complicated. Mm-hmm. In the spectrum of education, don't really need to worry about it too much. In our because we take you on that sort of spectrum as you go. And in our college program, it's about 5 semesters or about 2.5 years of part-time education.
And would I take courses in anatomy and perhaps nutrition?
Well, anatomy and physiology is a mandatory prerequisite before you go on to the advanced life support, where you're doing more aggressive care, you're starting IVs, you're giving a lot of medications, you're doing advanced airway care. That you wouldn't do that at the EMT or the entry-level position. EMT is the majority of EMS providers in America. but they don't have to have such advanced care.
But what strikes me, that what's interesting about your field is that it's not just academic. I mean, yes, you need to know the academics behind this, but at the end of the day, somebody's in pain, somebody needs emergency care right now, and somebody's got to make some pretty quick decisions.
Right.
Yeah, those are the things that you don't get taught in a classroom, and that tends to come with your length of service in the field. And it's also one of the things that's great about it is even if you're running the same type of call, say for instance, another diabetic or another accident, there are different patients and different people in different circumstances, and you just have to kind of learn how to adapt and overcome. When you first sort of start, I think you're a little bit startled. And then you kind of get to this place where it's like, okay, I've seen this before, I can handle it. And then you get to an area where it's like the medical portion of it, you studied so much because you're never really done studying in this field, it's second nature. But then that's when you can focus more on becoming more of a caregiver. You're a little bit of a psychologist, a psychiatrist, a hand holder, a friend. I mean, those things kind of come along as you progress in the profession.
Well, that's an interesting point, because you imagine the average person who's meeting you is scared at that very moment,
Yes.
right? So you've got to be that psychologist to
Yes.
calm them down in some way.
Yes, and I mean, I think that one of the best things that ever happened to my career was actually being a patient, because you can kind of go along in this, and it becomes kind of second nature of what to say and what to do, and you're just kind of repeating things that you think will help the person, but you never really kind of understand what that's like until you've been that person, and that gives you a whole new perspective on what it means to actually be a patient. And I think 100% it helps you when you get that person to say, I've been you, I understand you, and I know what you're going through, and I'm here, and I'm going to try to make this okay.
But how do we teach that I realize we can't completely teach it in the
Right.
classroom, but how do we try to teach that in the classroom? Can we teach that? Is that possible?
You mean that compassion?
And that ability
the
to
caring.
caringness and to really care right then and there.
Well, I think certainly people don't probably come, at least we hope not, come to the profession or want to come unless they are a caring person. But this assessment of what we call the affective domain, the affective personality traits, is becoming more and more of an important thing that we do evaluate in students, and we are emphasizing it, and it's being it's actually a critical criteria on all of our national registry skill sheets, and that's our national certification exam. So we are emphasizing more that you are not just doing the right cognitive testing abilities. Are you doing your IVs appropriately? Are you interpreting the EKG appropriately? But are you showing the right amount of compassion with not only the patient, but if it's, say, a scenario that is a parent with a child and that it's the sick child, are you showing the right interaction with the caregiver?
Well, my understanding is that this has been a big thing in a lot of medical schools as well.
Oh, yes, very much so. Right.
And it's important to understand that that everybody's not going to be cut out for the position, and that's okay. It's just going to be, up to you to sort of determine how much you can handle and in what area that you can best serve in this. And that's another good thing about the profession. There are many areas that you can actually serve without actually always having to be frontline with patients. And there's only so much, and I mean, I think Holly would agree, that you can take from the classroom, but it's going to be up to you as a person when you get out there, and there's a time where you have to spend sort of being evaluated by a higher level provider, that when you come across these different situations, you're going to have to take that when you're done and sort of reevaluate every call you go on and every year that you're in it and say, hey, is this still for me? And even, once you've been in the profession a long time, there's still that where you have to evaluate, hey, is this still what I can continue doing and serve best,
Mm-hmm.
But let's assume you're having trouble communicating with the people who you're serving. We've got millions of tourists who come here every year, right?
Oh, right.
Whatever percentage has to get sick at some point, right? And not all of the tourists speak English fluently, right? So what happens if all of a sudden you're called and you're near one of the Smithsonian's, and what do you do if you can't communicate with the person?
Well, we're lucky in that, we have tons of technology nowadays, and I know that within my department we have a language line, and a lot of our computer systems now have where you can tap on a certain button and type in a word and sort of, type in a sentence or phrase, and it will give you the language. Everyone has a smartphone at this point, pretty much, and so that's helped me quite a lot to have my smartphone on me, and they have a lot of voice recognition programs that can help you translate. And it's not always easy. It can be very frustrating, mostly because you want to help the person, but you have to try to understand. And that's something else that also comes along with, as long as you're in the profession, because if you're not worried about the care portion, when you have sort of hiccups like these that happen, you can still remain calm and do what you need to do to try to help. And there's always pointing and Pictionary, if you will. Do you agree?
Right. Oh, yeah. Well, I was going to say, we get a lot accomplished through sort of medical charades, if you will. And we often assess patients that are unconscious. And we get a lot of information, a surprising amount of information, just from tactile assessment, observation. We hook virtually every patient up to an EKG monitor. So even though we are certainly the blue-collar workers of medicine, if you will, we get a lot accomplished through our rudimentary assessment methods. And while I don't speak any other languages, I have assessed everything from patients speaking Russian to Farsi to everything else, and you get a lot accomplished through acting that out. Pictionary, medical Pictionary, I like
Pictionary.
that.
Fair enough. Well, in terms of the reference you just made in terms of your place in the medical world, how do you interact with the nursing profession, the doctors, the surgeons? How do you interact with them, or do you interact with them?
Oh, yeah, absolutely. Well, first of all, we communicate with them en route to the hospital. It's very important that they know what they're about to receive. And in an educational environment, we have a medical director that is essential in order for us to manage our program. And they have to assist us in creating our operating protocols. Like CC's agency has to have a medical director, at least one, if not multiple.
Yes, multiples. And then you also have to realize that, especially when you're in the street a lot, you're going to be interacting with these people quite a bit. When you're transporting people to the emergency room, you're going to be interacting with a nurse that essentially performs triage, which is where they take the information that you've received from the field. Sometimes doctors come over and do that, and you're in and out of these facilities so much. It behooves you to learn these people and learn their names and faces, because if you have to speak to them over the radio, if you're requesting some orders or information from them, you kind of want to know who you're talking to. You want them to understand you so that they know you as a provider and kind of understand your level of care. So we interact with these people quite a bit, and I work in an urban system. It's a very busy system. We're in and out of the hospital a lot, and because of my position as a supervisor, one of my tasks most days is to go into the hospitals to count beds and to make sure that they're not too busy, speak with the nurses, figure out how we can sort of help and continue what we call continuity of care, where it's like when they get care in the field, we want to sort of continue that throughout the ER and not sort of have it be like a stop-start new. So we do end up working with the people quite a bit, nurses and doctors and all.
So you might actually call and know the person who's answering the phone.
Yes.
And you might say something like, this is very, very serious, or this isn't that serious, or this is, I'm not sure how serious it is.
Yeah, I mean, it's something that, again, you learn as the profession goes on. When you're giving your report, you learn the things that are necessary to say so that the person on the other end understands. I mean, medical terminology is medical terminology. So you have to learn how to present that in a way where they understand that, number one, you understand what it is that you're seeing and working on, so they feel more comfortable allowing you to continue down that path or possibly go even further. And that, too, that they understand what they're about to receive. Because if we have what we consider most places priority 1 or high acuity patients, you want them to know what they're going to receive so that they know what type of medical care needs to come down to the emergency room to take care of that person.
Well, in terms, and you mentioned terminology, in terms of terminology and protocols, are they different from region to region and place to place?
Yes, in some places they are. We have a national standard, and there's an organization called the National Registry of EMTs, and they sort of set the levels that Holly was speaking about earlier. So it's not a requirement in some places, but most urban places around here it is. And so what you have is you have a basic level you have each level has their basic sort of set of circumstances, and then when you get into individual departments, the medical director would set, okay, maybe you can start IVs, or maybe you can, or maybe you can't, but everyone would be trained in that, but whether or not you can actually perform it, in your jurisdiction is up to that system. So the terminology itself would stay the same, and then the doctors and nurses in that environment sort of get an idea after a while of what your levels are and what you can perform. Do you agree with that, Holly?
I do, yes. I was going to go back to something else about you said about relationships. In the system, the volunteer system where Cece and I met many years ago, if you would call up, building those relationships, in other words, is very important, having a positive interaction with the whole medical team. When I would call in and I would say, this is paramedic Holly Frost and this is my patient, and whether it was a nurse or a doctor answering that, you would hear their tone of voice change. And, oh, I know Holly. And that would often be, and I'm sure Cece has the same relationship, you would get more likely to be approved for something. If I would call and want to perhaps skip a step in a protocol, for example. The protocol or guidelines are you should do A, B, C, D, E. And because of a specific patient scenario, I would want to skip A and go directly to B because it would be in the patient's best interest. And I would be calling to request permission to do that. And you hear the doctor's or nurse's voice change because they would know you and they would recognize you. And in a system with hundreds of medical providers, that's an important thing to have positive relationships.
Well, and how do you, but your students who are going through your classes have no relationships, right? Because they're starting. So how do you talk about that?
Well, you encourage them. Well, a lot of EMS education is clinical experience, as it is in all areas of medicine. What I say to my students all the time is sick people teach you far more than we ever could in a classroom. And it's true in medicine. My husband is a physician and he's about to finish his fellowship, which is his 11th year of medical education. 4 years of med school, 4 years of residency, and 3 years of fellowship. Well, basically that's a lot of time, more time spending with sick people than it was in the classroom, because the nuances of the human body give you slight variances of every single disease there possibly could be. So they spend, back to my students, spend hundreds and hundreds and hundreds of hours with patients. And that's a critical component. And so that is the philosophy being that they are spending time with patients, but they're also interacting with the entire medical community. And they have to learn to play well with others. And you're going to have preceptors that love to teach. You're going to have preceptors that don't love to teach. And you have to learn to be a little bit of a chameleon in how you interact with them. And therefore that teaches you how to work with partners in the future that will also have a spectrum of personalities. And even if they don't go on and pursue EMS as a career, as the two of us have, it'll teach you lessons about life regardless.
Well, and in terms of that communication, I think that's a fair point. Cece, in terms of that, do you have the same team that you communicate with every day, or do you start on day one and the team is together, or do you have different partners in every other day or every third day or every fourth day?
It depends on sort of where you are placed for the day. When I was riding on what they call a transport unit, which is basically the ambulance that people know, I would be assigned with the same partner, but there's vacation days and there's sick days, and then you can get a sort of a fill-in person. And like Holly said, you're going to have to learn how to interact with different personalities, and that plays with patients as well. Your patients are not always going to be the same, and you have to understand how to work with patients who are mean to you, who are nice to you, who are scared, who are younger, older. In my current field or current position, I'm lucky in that it's just myself in a car, but then I also have to deal with more personalities because I'm a supervisor, so I have to deal with a greater spectrum of people throughout the day. And even when I know the person, sometimes they're having a good day, a bad day, an up day, a down day, And they always look, to you to be sort of that center person, and keeping in mind that I may be having a good day or a bad day, but you have to sort of pull that together, because you have to be able to be a chameleon, like Holly said, and just kind of go, excuse me, with the flow of the day, the flow of the person, and overcome.
If you don't mind me saying, this sounds a little stressful. And what do you do to decompress at the end of the day? I mean, you've seen very bad things happen, and you've done a good job and saved people, but this is stressful.
It is, and everybody. That's again, it's something that you're going to learn as you go along in the profession. When I first started, it was sort of just my end of the day was, wow, I can't believe all of the things that I've seen. And then as I go along in the profession, it was like, wow, I can't believe all the things that I've seen. I think I just need to be alone for a little while. And then once you sort of digest all of that, you have to find something else to do, whether it's exercising, running. I like to read, I like to bowl. You have to find a way to leave this behind. And it's a little hard in the beginning to not hear sirens and want to take a look, whereas I think now once you get sort of in your career, I can hear a siren and I can keep on going, because when I'm not there dealing with it, you have to be able to separate yourself from it. And it's not something you can teach. It's something that you have to learn, and if you don't learn it, your career will definitely be short, because it will take a toll on you and it will burn you out.
Do you address some of this in the classroom?
Oh, very much so, yes. Well, we have a built-in, I call it built-in group therapy. You, as opposed to police officers who are generally alone in their patrol car, you always have at least one other person in your ambulance. And you probably went to that scene with your ambulance and an engine crew and a fire truck. And so while you didn't see exactly the same thing, because you don't do everything together, you have an opportunity and probably to some degree have to talk about that call afterwards. And so you have an opportunity to debrief, so to speak. And that's an important exercise. And not everyone gets a benefit out of talking through things. Some people prefer to go and be alone. But that has been shown to be very beneficial, to have an opportunity to do some sort of stress relief. And that's what we know in our profession to be the case. I've been a paramedic for over 30 years. When I first started, everybody was supposed to be John Wayne, hold it in, show emotion, and you were a weakness, you're a weakling. I came in as one of the few women I was in Denver, and very few women were at that time, and that was just not me. The pendulum swung the other direction, and then everybody was supposed to cry at the end of an emotional call, and if you didn't, there was something wrong with you. We've now come to a more reasonable, middle of the road, but everyone has recognized we have an extraordinarily stressful profession, and that this sort of emotional debriefing is important. I have a little exercise I do in the classroom. Our computers take a while to warm up, and as I'm warming up at the beginning of a lecture, I will say, who's had a good call? And a good call in our profession is not what you would call a good call, meaning a big one, and then somebody will always say, well, here, I ran that. And then we'll discuss it as a class. It's not violating HIPAA. Nobody's telling an address or a name, and then we'll discuss it as a group. And it gives the opportunity to bring up any sort of topics, medical, pathophysiologic, but also to talk about, and my students know I'm a warm and fuzzy person anyway, so it gives me an opportunity to bring up any of those dynamics.
So you mean you're warm and fuzzy if the person's bleeding a lot compared to just a little?
Well, I always use it as an exercise also to discuss anything like, wow, that was, how did that feel? Was that an emotional thing for you? Did you guys discuss that? Did anybody bring up any need for what we call a critical incident stress debriefing?
But wouldn't you be scared if a person is bleeding a lot as opposed to a little? I mean, as just someone who's not an EMS provider, aren't you scared?
It's where your training comes into play, and when you first start, I think you sort of have this terror on the inside that sometimes can come to the outside, and as you progress in the profession, sometimes you feel like your guts are churning on the inside, but then you learn that you have to keep it together on the outside, especially when you get in a position where other people look to you for calm and comfort. And if you have a paramedic that's at a scene and they're kind of frazzled and running around, then that's what the scene's going to be like. And if you go and you're calm and you speak in a calm voice, even on the inside, you're still like, okay, this is out of control. But if you portray that on the outside, your members tend to take that cue from you, you hope, and everything can be calm, and your patient takes that cue from you. And then it just becomes second nature because you've trained for these things, and it's going to be okay. You know, you train for these things, you do what your training tells you to do, and it's just a matter of taking a deep breath, calming down, and going through the steps, and making sure that you provide the best care possible.
Well, I am taking a deep breath, but we only have 1 minute left
Okay.
or so. Can you just give us some viewers some last minute tips that, because I'm stressed. I'm thinking, wow, this is a tough job.
Right.
But what tips would you have for somebody thinking about going into this field?
I would just say that you really should probably research it more than you think. Like what Holly said in the beginning, a lot of people I think are drawn to it because they have an idea of what it might be like. But for me, myself, and for Holly as well, we started as volunteers, and it gives you a chance to get your foot in the door and learn what's going on, run a few calls, and you have to just be okay with understanding that if it's not for you, it's not for you. So if you get out there and you just get your foot in the door, try a few things, and make sure that you can handle the bleeding and the crying and all of those things that come along with it, then it would help you quite a bit.
Well, I would say, actually, the more EMTs that we have in the world, the better. Obviously, Boston bombing and what happened in West Texas are testimony to that. And what a lot of people don't know is 100% of the responders to the West Texas bombing, or explosion rather, were volunteers. Mm-hmm. And they did a remarkable job. And so the more first responders that we have in the world, the better off we all are. And you can do EMT and not invest that much time and effort. See if it's for you. And for most, it won't be. They'll say, this is great knowledge, but it's too much for me to pursue, but that's okay. You have great information.
Well, fair enough. Good luck to both of you.
Thank you.
If you would like additional information about Holly Frost or CC Wilson, please visit nvcc.edu or fems.dc.gov. If you have comments or suggestions about higher education today, please send an email to our viewer mailbox at highereducationtoday@topcolleges.com. Thank you for watching. We will continue to bring you quality discussions about important matters in today's college and university world. Please join me again for another edition of Higher Education Today. I'm Steven Roy Goodman, and you've been watching Higher Education Today.